Welcome to Delaware Healthcare Reality, a podcast presentation of the Medical Society of Delaware with Dr. Nicholas Biasotto. Dr. Biasotto is board certified in family medicine, and he has extensive experience and training in treating patients with addiction and substance abuse. Now, let's join Dr. Nick Biasotto for Delaware Healthcare Reality.
Hello, this is Dr. Nick Biasotto, host of the Medical Society of Delaware's podcast, Delaware Healthcare Reality. Our subject today is regenerative medicine, and we have an expert here today, a Dr. Joe Straight, who's going to fill us in on all the details of regenerative medicine, platelet-rich plasma, and we're going to touch on stem cells if we can. Dr. Joe Straight received his BA from the University of Delaware. He also then went to Delaware Technical College and then received his medical degree from Jefferson Medical College of Thomas Jefferson University. He was Christiana Care's healthcare system resident between 2004 and 2007, and he did his fellowship at Christiana Care in sports medicine. He presently is working for State Orthopaedics. He's their sports medicine guy, and he's also one very into regenerative medicine. And he is presently also the affiliate assistant professor at the University of Delaware Department of Physical Therapy. Welcome, Joe. How are you?
Nick, thank you very much for that wonderful introduction.
Also, I failed to mention that you were a former president of the Medical Society, as I was.
It was a great time. It was during the pandemic.
Oh, that was a good time.
Good time for 2020 to 21, and I know that myself and Mark Thompson really enjoyed that year with all the things that had to happen in the state of Delaware. So
I remember a hell of a year it was. A couple of years it was.
It definitely was.
All right. Well, now we're going to talk about platelet-rich plasma, which are platelets that you inject in a patient's joints, for example. Can you define what platelet-rich plasma is and how you do it and how you harvest the platelets, etc.?
So I'm going to start by just going over, regenerative medicine has been around for a long time.
Okay.
There was people who started with things like prolotherapy. I don't know if you've ever heard of that, but that was using like dextrose or sugar water. And the thought process is that you were trying to stimulate a healing response. You'll hear words like neovascularization. It's been around for a long time, PRP. The European countries are ahead of us. I mean, currently, I could probably name 10 to 15 countries that have been doing regenerative medicine. You'll see out there that a lot of famous people, Kobe Bryant, he's had PRP and stem cells done over in Germany. You'll see Joe Rogan, who does one of these as well, and he talks about PRP being done in Panama as well as Mexico. So you have a lot of people who actually go out of country for this. So PRP, which is platelet-rich plasma, is a fairly easy procedure. It's using your own blood. And what we do is we draw blood, usually out of the antecubital fossa of the arm, the easiest spot. It could be anywhere from 15 cc's. I've drawn up to 160 cc's, depending on how much product is needed. And we can get into that later, but each of the different companies out there, and I'll just throw a couple companies out there, Terumo through their Harvest products, and Arthrex, they have different machines. And there's many more. You can go on the internet and find tons of them. Each of them need a specific amount of blood that can be centrifuged, right, or spun. We call it spun or runoff. But it's using a regular centrifuge that they provide, and it separates the cells of your blood. And everybody knows of the red blood cell. Well, that's actually something we don't want to use, right? We get rid of the red blood cells. But the yellow portion, called the plasma, is where our platelets get spun into, and that's where they live. And our platelets are where our growth factors are. And I'm not going to go through every growth factor, but there's tons of growth factors that help in healing. So I'll start with you've done this in the past, right?
Correct.
You were part of wound care for a long time. You have great experience in it. But we started back a long time ago with wound care, and they used platelets in wound care, right? It was clotting of blood. And it also helped with healing. So this has just been extrapolated and moved into different fields. So in the United States right now, you see it in wound care, which it's been going on for a while. You see it in dentistry. You see it in orthopedics or sports medicine. It can be used in the office as an injection. It actually can be applied during surgery. That's been going on for a while as well. It's also done in plastics, cosmetics, wrinkles. You hear about Botox. Nobody hears about PRP, but it's a great treatment for that. Also hair growth. So that's where it kind of has evolved.
I could use the hair growth part.
I could too.
Go ahead.
But veterinary medicine. So I always talk to patients in the office because we use things called hyaluronic acids or HA injections. People have called them rooster combs or gels. But they actually started in the use of animals, horses, right? So a lot of the stuff we've done has been already used in horses. And PRP is actually used in horses as well. So what we do is we draw blood. We put it in a machine. It's centrifuge. It's centrifuged down. And we actually take off the plasma part. And we want the part that is at the bottom predominantly of the plasma. So there's some plasma poor, right? And there's plasma rich. And it just depends on how much you want. Most of the systems that we use in the wheelhouse ranges is somewhere between 2 and 10. And what do I mean by 2 and 10? 2 and 10 times your normal body's ability to have a response with platelets. So when we say concentrated, we're talking usually somewhere between 5 and 7. That's where the wheelhouse that I use. A lot of studies are out there. They'll tell you what they've used. So that's what we're trying to do to heighten the response. Now, people think it's going to stay there for a long time. It's actually not. We really get a healing response in 3 to 4 days, right? The goal of it is to promote healing in the tissue. We use the word regeneration. Yes, we're trying to regenerate tissue. I would never say that it heals everything. So a lot of patients think that when they have bone-on-bone arthritis in their knee, and we use things like PRP or even stem cells, that it's going to fix everything in their knee. And that's not the case.
Okay. Well, as you mentioned, I had a lot of experience with this, and this was 30 years ago when the company that ran, in conjunction with Christiana Care, ran the wound care centers. We would isolate platelets, make a poultice out of those platelets, and we would apply it to the wound bed. Now, I'm going to tell you anecdotally, no studies to back it up from my point of view, but anecdotally, it would make a gray, sick-looking wound in a week look beefy red and healthy. So platelets did do quite a bit to help maintain people's legs that were suffering from potentially having an amputation to having a wound that is easily and capable of being treated and apply skin substitutes or skin grafts to the area. I was impressed with it. However, it was not cost effective, and it was discontinued for that reason. And obviously the government or the Medicare or any insurer would not pay for the system to have that done. And it was a rather expensive procedure. So that's my experience with it, and I could tell you that platelets really have a great deal to do with wound healing, and that's what happens once you get a wound. Thrombocytes, which hold the platelets, rupture and release the platelets to the area, and the platelets bring tons of growth factors, as you mentioned, one of them being a vascular endothelial growth factor. And as it says, vascular meaning blood vessels, forms new blood vessels, bringing more oxygen and more healing potential to that wound, as it does, I'm sure, in a joint. It's very interesting to see how this all works. Can you tell me, I've read some articles on PRP, and some have said this joint it works, that joint it doesn't. What joints does the PRP show its greatest effect?
Well, if you've done your reading, as you said, you'll see that most of the research and the articles are predominantly on knee joint arthritis.
Correct.
Right? Or tennis elbow,
Mm-hmm.
or what we call lateral epicondylosis or common extender tendon pathologies.
Correct.
There's other studies out there, and I think that was the downside of trying to do PRP 10 to 15 years ago. And it was, there's no studies, there's no studies, there's no studies. And there's a lot of studies out there now. So best joints, and we're going to talk joints and then soft tissue. Predominantly the knee joint has been what I've used PRP for.
Mm-hmm.
I do explain to patients that in my practice I have seen that stem cells with PRP do a better job in joints. I don't know why that is. I go online and I research the stuff just like you do.
Mm-hmm.
There's a gentleman named Jeffrey Peng, P-E-N-G.
I've run across that name. Mm-hmm.
And if you look at the literature that's coming out and you read what he has said or listen to what he said, it's actually about the same, PRP versus PRP and stem cells in the knee joint.
The same result from both.
Same outcome. And they look at like knee scores from pain, right? They're not looking at is there regeneration. They're not going back and scoping the knee to see if the cartilage has grown. They're not going back and doing repeat MRIs to show that there's better cartilage present. But I'll just say from a joint perspective, I've seen that the knee joint is probably the best. Have I done other joints? Definitely. I've stem celled and PRP'd finger joints, the thumb IP joint, the CMC joint of the thumb or the first CMC joint.
Mm-hmm.
I have PRP'd and stem celled elbow joints, shoulder joints, knee joints, ankle joints. I have not done many hip joints.
Mm-hmm.
A lot of those patients that have arthritis in their hip go on to have a hip replacement. It's just a slightly easier procedure to come through than a knee replacement.
Mm-hmm.
Now,
but it's not as easy to get a platelet shot.
It's not, and the thing is that I explain to patients that the goal of my procedures, PRP as well as PRP and stem cells, is to give them decreased pain, decreased swelling or effusion in the joint, if I'm doing a joint, and improved function.
Mm-hmm.
And I think that if you spill it like that to patients, they can understand. And why I mean that is they may come back a year later and they're feeling great, but the x-ray doesn't show that they have bigger joint space or lost their spurs or enthesophytes,
mm-hmm.
right? So I explain that to patients because they may feel great, but they want to know, well, wait, it didn't make me have joint space again. Well, it's not going to.
No.
So going to soft tissue, I think that's where the PRP has been the most beneficial in my practice.
Like what?
So my favorite two spots are tennis elbow,
mm-hmm.
lateral epicondyle.
Mm-hmm.
I will even say medial epicondyle does well, like golfer's elbow. So the elbow, very good. I've also seen it very, very effective in gluteal tendon pathology, which is significant in trying to help middle-aged and older people who have back problems ambulate. Because tons of them have pain and tenderness over the lateral aspect of their hip,
mm-hmm.
over that greater troch that's sore and tender.
Mm-hmm.
And when they walk, they're using their abductor,
mm-hmm.
right, to lift their leg to step.
Right.
And that abductor, which is your glutes,
Yep.
causes a lot of pain.
Got it.
So I think that's the two best spots.
Well, you mentioned hips, and you don't do too much, but in my research it says it really doesn't show much of a benefit over a corticosteroid injection or hyaluronic acid. The knee, this is in research that I've done, shows it's the best results in the knee. And you're getting it in your practice through injection of the many joints that you have, seeing it work in other joints. Well, that's a VAS score, a VAS as they call it.
Yes.
A visual, in other words, the patient saying, I feel better.
That's
and you're
correct.
saying, okay, that's a good thing, it's working. As opposed to studies which show that their motion is improved, their this is improved, or that is improved, their pain level definitely goes down because that's how the patient judges whether the injections have worked or not.
That's how I personally judge everything I do in my office.
So it's a VAS score, a visual analog scale. Okay.
Correct.
Well, that's pretty interesting. Tell me why, however, and this is one of the biggest bugaboos that we had at Wound Care, is it's not reimbursed by insurance companies, and Medicare has not recognized it as a procedure that has worked. The studies are still lacking according to Medicare or CMS, who does determine how much everything gets paid for. When do you expect this to change, or do you?
I'm hoping soon. Because I'll tell you this, being in an orthopedic office as a sports medicine doctor, I do not have a lot to offer patients. And I know that sounds crazy to say this, but patients come in, and if they have a tendon issue, we'll just start with tennis elbow because it's the most common. Mm-hmm. So the tendon itself becomes thickened or tendinotic, or we call it tendinopathy. Mm-hmm. And the tendon itself starts to tear. Well, that tendon's going to continue to tear. It does not have an ability to heal. Right? So when I put steroid there...
But due to the lack of blood supply, correct?
Well,
that's why it doesn't heal
tendons
too much.
don't have a blood supply directly in the tendon.
Correct. Go ahead.
So the steroid does a great job initially. It is a great pain reliever. It's an anti-inflammatory and pain reliever. Patients walk out of the office happy as can be. Mm-hmm. We immobilize the wrist so that we keep it from functioning for a short period at the elbow. We put them in a tennis elbow strap, right? Mm-hmm. They go to therapy. They seem to come back between 3 and 6 months.
Same thing.
And the same problem's there. They still have tenderness. They still have functional issues with their hand, grasping, grabbing, lifting things, especially you go to pick up your coffee pot and, wow, my elbow hurts. The findings that I've had in my own office clinically, patients that have PRP procedures of the tennis elbow mm-hmm. do excellent for way longer. And what do I mean? Years.
Really?
Their pain levels, their function of their hand and wrist, years.
I can agree with you because I will inject joints with corticosteroids. I don't do the PRP. I don't have the fancy get up to do it, but I do them in joints such as knees, shoulders, tennis elbow, etc., with good relief, but 3 to 6 months maximum on most of it, and then they come back and say they need another. I think this present situation is that they say you can maybe inject 4 shots in the same joint in 1 year.
So what we tell people is every 3 months. Mm-hmm. There's actually this is off of the PRP side, but there's actually a study at the University of Delaware going on with one of my old, I'll say colleagues, but I guess he was my mentor, mm-hmm. and he's actually proving right now that the steroids don't degrade cartilage.
Good.
There was a thought process that before that steroids killed your cartilage, and that's why you weren't supposed to get so many. So I'm hoping that literature is going to come out in the next year. Mm-hmm. But going back to your initial question about the literature's plentiful. It's plentiful. There's a lot of literature out there on PRP and stem cells. Mm-hmm. It's in multiple countries. Like I said, it was happening in Europe way before us. I don't know why it's not an approved treatment. Because as I was walking in here and having a conversation with some of the medical society people, that is one of the downfalls of PRP and stem cells is the cost. Mm-hmm. Patients would love to do it but can't afford it. And I think that if we started to look at getting coverage under whether it's our commercial insurances, Medicare, the new Advantage plans, it'll lower the cost. I think that it'll lower the cost of these products across the board through these companies. It has happened with HA injections. Mm-hmm. I use that as an example. HA injections were very expensive before. They are not as expensive anymore, right? Approved. And we know now from studies, head-to-head, PRP versus HA in a knee joint arthritis, PRP is superior.
Yes.
Now, we are doing studies, and there's already some studies out with if you combine the two, they do better than just each of them individually.
Wow, interesting.
So that's another thing that I am now offering to patients, that if they want to do their HA injections, which a lot of people are on an every 6-month HA injection, they come in and they get a series of 3 or a 1 shot, depending on what they like. We are now talking about doing PRP with that.
So you will get some reimbursement due to hyaluronic acid.
Well, that is separate.
Okay.
There's no reimbursement for the actual injection or product of PRP or stem cells across the commercial or federals. I have had occasionally workman's compensation in the state of Delaware, which I do a lot of. They've understood that it's a good treatment for patients to avoid surgery, which is a higher cost.
True. How much does it cost? If I come in and I say, oh, Joe, I need a shot in my knee. I've had a couple steroid injections. It just didn't solve the problem. Can you do PRP on me? What's the cost?
So let's start with PRP. All right. This is all regional. All right. Completely regional. So you'll hear patients go to Panama or Mexico.
Really?
It's cheaper. Right? It's cheaper.
Yeah, but the flight, the hotel, everything else adds it up, right?
Understood, but it is cheaper.
Okay.
Right? Europe, cheaper. In the United States, I'm saying it's more commercialized. Let's be honest. We have a company that's providing the machine, making the products, the things that are needed to perform the procedure, right? Even though it's coming from your own arm and going back into your own arm or body, right? So ranges anywhere from $500 to $1,500 is what you're going to see in our region. If you go to Florida, so I know a lot of doctors who have left. I worked under a doctor at Christianacare who moved to Pennsylvania. He is now in Florida. You go to Naples, it's a little bit more expensive. Yeah, it's regional. There's more money there.
You go to Boca, it's probably even more expensive.
and that's the problem with out-of-pocket services. I am not a sales rep. I am not a salesman. I am a physician. I try to do the best I can for patients.
Okay.
So it's hard to sell something to somebody.
Right.
I don't want to have to sell it.
None of us
And
do.
that's the hardest thing that I have when I'm trying to talk about PRP and stem cells.
Got it.
Now, stem cells, a little bit more expensive.
Oh, yeah.
They can range up to crazy numbers. I've seen $50,000 for some procedures. That's off the wall. I can tell you, in my own office, we charge anywhere between $3,500 and $4,500 for a stem cell procedure, depending on what we do. And that automatically comes with a PRP injection, too. I use them both collectively together. I don't do stem cells separately.
Okay.
In our office as well, PRP ranges from anywhere from $750 to $1,250 per injection.
Got it. Well, I think it's a good time here now to take a break. We're going to come back more and talk a little bit more about PRP, and then we're going to add some stem cell information to the audience. So we'll be back shortly. Hello, everyone. We're back from our break now, and I have a couple more questions for Dr. Joe Straight, who has given us some valuable information on PRP and how it works. That's platelet-rich plasma. That's what the PRP stands for. Can you tell me why Europe was ahead of us on this?
I don't. That was way before me. I'll be
far
honest.
back it went.
Oh, 100%. So, I mean, think about it. It was Kobe Bryant early in his career. So I will say I've been doing PRP in my office for about 10 years now.
And it was before that.
It was way before that.
He
did stem cells.
Is it reimbursed out in Europe? I guess it is, because it's less cost, you said, in Mexico to go get it done, correct?
So a lot of it's out of pocket, but it's just less.
Got it. Tell me some of the indications for platelet-rich plasma. I would come to you and say, what? Pick the joint.
Well, I'm going to go through them real fast, just in general. Okay, so we're going to go over individual things. Let's go muscle, tendon, ligament. Muscle, tendon, ligament, we're going to call soft tissue.
Okay.
So I'm going to tell you what the indications are in general, and I'll tell you how I use them.
Okay.
So you will see for anything from an acute injury to a chronic muscle tear, right? You'll see it for acute injuries of tendons as well as chronic tendon problems, and usually chronic ligamentous problems.
Okay.
Right? In my office, I do not use this acutely. Okay? And what does that mean? So if someone comes in and tears their hamstring, I don't go right to sticking PRP into the hamstring muscle or tendon.
Okay.
I usually do the normal conservative measures, like everybody else does. Compression, heat, ice, stretching, therapy, rehab it.
Okay.
If it doesn't get better and patients are not happy with their outcomes or don't have improvement in certain things, then we talk about those.
Got it.
For the PRP.
Okay.
PRP for joints.
Yes.
So PRP for joints, Again, I told you earlier, I use stem cells with it predominantly. I'm doing more PRP without stem cells because patients are asking for that. Mm-hmm. We are doing that as a secondary treatment in my office.
Okay.
Indication, knee pain, knee swelling, hasn't gotten better with steroids, hyaluronic acids, and conservative measures to include medications, therapy, bracing, etc. Mm-hmm. So that is how I use it in my own office.
Okay.
Again, stem cells, a little bit different. I use them only in joints. I am not putting stem cells into tendons and soft tissue. I have not seen the need. Mm-hmm. And if the literature starts to show what Dr. Peng has said, I may not need to use stem cells down the road, but we'll see.
Okay.
We'll see what the literature looks like. But usually, again, this is a secondary treatment. I am not seeing someone initially saying, hey, you have mild arthritis in your knee, let's do a stem cell procedure. I don't come at it like that. I treat them with the normal conservative measures, and if it fails and there's no surgery to help them, I then use that as a secondary treatment.
Got it.
I have done occasionally pothole defects. What do I mean? The cartilage on our bone is called hyaline cartilage. Mm-hmm. If there is a focal area that's been injured from an injury, I have used stem cells and PRP for those treatments, more of an acute setting.
Okay.
And this leads to, we don't usually go back and do MRIs or anything after to prove that there's been cartilage growth, but there's been two people in my practice who, actually one worked for myself, and they had a pothole defect in the anterior compartment, which is called the patellofemoral compartment, and I stem celled her knee, and actually 3 months later I got a repeat MRI, and I sent it to the two radiologists that work for our practice, and they could not find the pothole lesion again.
Wow.
So it was encouraging to me to see that maybe there was some kind of improvement, healing, cell growth, cartilage improvement. Could I tell that it was hyaline cartilage? No. It could have been a fibrous cartilage that developed from the. Wouldn't know that unless you went in and you biopsied it. But we don't do that.
How about Achilles tendinopathy?
It works
I see
great.
that in my office. It works great?
It works great.
Literature says it was lacking. Evidence was lacking. But you say it works great, huh?
It is, but in clinical practice, the Achilles is a really hard tendon to get better. I have people who are in 8 to 9 months of physical therapy for Achilles.
I've ruptured mine, so
very
I know that.
Thickened,
yeah.
And it starts to tear like a rotator cuff inside, and then it can rip off.
Yep.
Usually when it rips off,
surgery.
We usually recommend surgery. There's some people that go non-op in a boot for a while. But I have seen this, and I've done this both acutely and chronically. A chronic Achilles tendonitis, especially insertional, it works very, very well.
Good, good. All right, we've talked about the indications. How about the contraindications to platelet-rich plasma?
So I have very, very little contraindications. I know I will do a little bit more than most people. If you read, there's a lot of stuff about being on anticoagulants, right? And the biggest issue is this platelet number, right? If they have very low platelet numbers, even if you concentrate it 5 to 7 times, what are you getting?
Thrombocytopenia, as it's called.
That's correct.
Lack of thrombocytes, lack of platelets.
Low platelets, right? So patients that have very low platelets, we counsel them that the outcomes aren't as good. People who are on anticoagulants, sometimes we have them go off the anticoagulants if they can for a specific amount of time prior. That's about all I really have. Now, stem cells are a little bit different.
Let me get to that. Still with this now. We were told when I was doing it 30 years ago, active malignancies, because you develop, particularly with vascular endothelial growth factor, they felt that they would increase the blood supply to the malignancy and make it grow. Even those studies done by the company that developed this, they labeled it Procurin, the company said that studies have shown it does nothing to malignancy. But would you do something in an active malignancy?
PRP I have done.
Okay.
Stem cells is where I will
Hold
not.
the line. Okay.
I will not.
All right. Being it's allographic, it's same body, it's a person's blood. They very rarely have any allergic reactions to the problem, do they?
I have never had, knock on wood, I have not had any kind of significant side effect.
Got it.
You're using your own blood, you're putting it in your own tissue, and I like to run through it for patients at some point. of how it goes, but people don't understand. PRP actually hurts when it's being injected into tissue. Into the joint, it does not cause pain. So people have to understand that you can't use anti-inflammatories a certain amount of time before, usually 5 to 7 days, and after that, 1 to 2 weeks, depending on whose protocol you go by.
Okay.
So the anti-inflammatory shuts down the healing response.
Exactly.
So we don't want that, and we don't want that before or after.
Got it.
So it hurts while you're injecting it. There is some people around the area using a little bit of something called ropivacaine. That is a specific anesthetic,
Correct.
like lidocaine, but you can't use lidocaine because lidocaine has been shown to affect the cells. So we do not inject PRP with a numbing agent, so it hurts.
So bupivacaine is out of the picture too, right?
100%.
So you don't want to use anything. You got to go in without any anesthetic. Generally, the hardest thing I find in joint is that once you get through the skin, they don't, and you don't hit the bone or something.
The joint will not hurt.
Right.
The joint's an open space. You're putting into the joint. It's the tissue. So if you're doing a tennis elbow, a gluteal tendon, Achilles hurts a good bit because it is a compact piece of tissue, and you're putting a volume into that tissue that's bad.
Exactly. The stretch alone makes the pain. All right, that seems to be a good overview of stem cell, of platelet-rich plasma. How about stem cell therapy? Tell me a little bit more about that, how you do it, where you get your stem cells from, etc.
So there's 3 different ways, and I'll say currently in my practice, I'm only doing 2 of those 3 ways. There is something called BMAC. We use a lot of terms and initials, but it's called bone marrow aspirate concentrate.
Where'd you get it from?
Well, so you can take it from multiple sites about the body. We'll give you a couple of them. Is the PSIS, or the posterior superior iliac spine of the pelvis. That's the most common spot. It's the easiest spot for myself to take it from. You can take it from the tibia. You can take it from the calcaneus. So it can be taken from different bones. Procedures are, how to do the procedures are set. There's, you can actually watch videos online of how the procedures are done. So what it is I call it a jamshidi needle. It's got like a little corkscrew. You literally make a little incision in the skin. After you numb it, you can numb the skin. And then you work your way down to the bone. And you literally slowly just break through the cortex of the bone and go into the marrow.
That must hurt.
So actually, you would think it would hurt a lot more. It does cause some discomfort. The biggest thing that I hear is that there is cramping in the buttocks on the same side of the pelvis that you're going into. More of a cramp ache in the buttocks itself. It's relieved once it is removed. I've never had a problem with the site itself. We tell people there's a risk of infection. I've never had one of those. Patients heal there. They don't usually have tenderness or pain there after the healing of the tissue, the skin tissue. Then what happens is, similar to PRP, the blood that's taken from the bone marrow, usually somewhere between 60 and 90 cc's, depending on, again, the product you use, that is put into a machine. Now, that machine is specific because it has to have a filter. It takes out bone chips and things like that. And it's spun the same way, and it centrifuges and separates. Now, we don't get a ton of product from 60 to 90 cc's of bone marrow. We get maybe 1 cc. So the other way to do this is to actually use cadaver stem cells, where, again, that now takes it, not your body, but somebody else's. And there is different companies out there that actually have different types of cadaver stem cells. And what I caution everyone on, stem cells are not all the same. There's MSCs, mesenchymal stem cells. That is what grows cartilage, bone, tendon, ligament, all of our musculoskeletal stuff. So when you talk to someone about stem cell procedures, you need to know that there's mesenchymal stem cells. So you can actually get this from vertebral bodies of patients who have expired. You can actually get these, we call them, they're frozen, right? And just like is used in the OR. So I liken it to if you're having a procedure done in your knee in the OR, they use things like bone chips and stem cells and putty to actually build bone. It's the same products.
Amazing. How do you see the effectiveness of it? Do you actually see tissue growth? Because that's what stem cells are supposed to do, aren't they? Help you grow the tissue?
So I do not tell patients that.
Okay.
I do not.
You didn't hear that,
straight. No. I tell patients that the goal of this is to help promote healing and regeneration of their tissue. I tell them again, function, decrease pain, decrease swelling.
Right.
And that's what I've seen from the use of PRP and stem cells in joints. Mm-hmm. Patients come back, they don't have effusions. They feel better. They're able to do more. My average, I would say, amount of time that I get for patients is about 2 years. From the time I've done it up to about 2 years, I see that they do way better. That would be an average across the board of all the patients I've done.
Are there any imaging that proves that there is an increase in
Can you do that? Yes. It's not usually done.
But does that show that there has been tissue regeneration?
I have not done repeat imaging like you're talking MRI to see cartilage. I have not done that on our patients that are arthritic and have stem cell procedures. Like I said, I did do that on people who had a pothole lesion where it was just a small defect. I wanted to see if it would fill in a small defect. And it did.
Well,
I have done it in tendon work.
Okay.
So if you're doing, I'm going back to PRP because, like I said, I don't do stem cells in tendons, but I've actually had MRIs where I've PRP'd a distal biceps, which is the tendon that hooks your biceps to your forearm. Uh-huh. And I PRP'd this, and I sent the patient 6 months later with an MRI, and it was read at the same facility, and it said resolution of distal biceps tendinopathy. They had both MRIs. They were able to compare those. So I do think that in tendons and soft tissue, we are seeing definite tissue healing, regeneration, or just improvement in the tissue quality. I have not really done a lot of backup imaging on joints.
Well, stem cells in the past, I forget what presidency it was, they were anti-harvesting of stem cells from embryos and things like that. Obviously, because of the controversy for abortion and da-da-da. But they do use stem cells from the placenta. And people store them and keep them. They have had them cryoed. And they say that something happens to me later, I'm going to have, or somebody needs them in my genetics, we can have stem cells to help them recover.
So I do not know.
I know you do.
I don't know about that well, but I will say this: that is happening. Yes, people who are saving, cords and fluid and things like that, and keeping them in banks, and they can go back and use them themselves. So I'll say this: there are products on the market from an amniotic standpoint, from a placental standpoint, that are predominantly frozen products that say they have stem cells, and this is where the word stem cells can be different things. Mesenchymal stem cells versus just pluripotent stem cells.
I mean, they can become anything.
They can become anything.
Right.
So there's lots of companies using these. I see it a lot more in the foot and ankle world. They are slightly cheaper. I will say that I got the most benefit out of a stem cell procedure. The PRP did very well for about 9 to 12 months. And I'm now back, and this is what's really odd about it, I'm back to using steroid in my own knee, and I'm 3 years on my last steroid injection where I was only getting 3 months prior.
Oh.
So there may be also an environmental effect on the lining of the joint, the synovium, and this environment of the joint itself. The consumer, or even the medical field out there, should understand what they have to go through. So I'll take it one step at a time. Patients usually have a consultation. We go over their options. We talk about the options. We talk about being out of pocket. We explain to them how it has to be paid and separated for them because it's hard to pay it all up front, right? And then we give them an understanding of what their pre- and post-procedural plan of care is. They need to know what they have to do before the procedure. They need to know what they have to do after the procedure. And that is very important, especially with tendon and ligament work, because people have to understand the shot doesn't just fix it, it helps it, but you have to do the other stuff. And I had said earlier...
Is it immobilization that you do? It's all immobilization? Okay.
So there is. So like you brought up the Achilles.
Yes.
I immobilize the Achilles for a lot longer than I do a tennis elbow.
I believe
so
that.
People leave my office in a sling for tennis elbow and a boot for an Achilles. I start physical therapy somewhere between 10 and 14 days after all my PRP procedures on my tendons. Not as much with my joints. So they need to go through physical therapy. I had said earlier, no anti-inflammatories. If I inject somebody and they go home and use anti-inflammatories, they actually are probably decreasing the efficacy of the procedure. We tell them Tylenol. We tell them heat. Heat brings blood flow. Heat helps bring more blood flow, and that's what we want. Mm-hmm. So usually I have the patient follow up with me at 2 weeks after. I put them in physical therapy. Usually the physical therapy course is to work on first motion. So if you inject PRP into the elbow tendon, the lateral epicondyle, they have a hard time starting with motion, especially in the first week, because it hurts, right? And it lingers. When they come back, they're usually back to baseline. Well, just before I did the procedure, they're about at baseline. They're not usually better. Where they get better is week 2 through week 8. And we see this actual improvement up to 90 days, 3 months from the procedure. So some patients come back and say 85% at 6 weeks, and they'll come back at 3 months and be like, it's gone. And that's a normal progression from a PRP procedure. So yes, there is some immobilization. There is physical therapy. There's avoiding certain things like NSAIDs and ice after procedure.
Speaking about NSAIDs, it's usually when you cut yourself. Let's say you just had a cut. And, day 1, day 2, day 3, it's all red. Everybody says, oh, it's infected. That's the inflammatory reaction. And with a non-steroidal, you inhibit the inflammatory reaction, which in turn inhibits healing. That makes a whole lot of sense.
Nick, I've been doing this for years, and maybe I'm wrong, but I have people who sprain their ankle, and I tell them, don't take an anti-inflammatory the first 4 days.
Oh,
or if they hurt their elbow bowling, I say, don't. And they're like, why? I want there to be an inflammatory response that's not knocked down.
Good point. That's a very good point. If there's no takeaway from anything we've said here today, that's probably one of the more important points. Anything else, Joe? I think this has been one interesting conversation. Do you have anything to add?
No, I think it's the future.
I do too.
I really do.
I do too.
And I'll say this, starting this 10 years ago in an orthopedic group that I grew up in and had multiple knee surgeries with the docs there wasn't as much buy-in. And when I say that is you're an orthopedic surgeon. You operate on things.
Right.
And I respect that. But we are starting to see more and more orthopedic surgeons be involved in the, I'll say, regenerative medicines, whether it's just PRP versus stem cells. I'm getting more referrals for PRP because we don't have anything more than steroids and surgery, right? I mean, really, that's all we have.
So I think that acid, I guess. Yeah.
It is, but like I said, you're seeing that start to go away.
And replaced.
We hear that may be gone soon. I think it needs to be replaced by something like PRP or a regenerative type treatment.
Great. I think this has been a wonderful conversation, Joe. I appreciate it. I think our people that are listening should understand what you've said. We've said it in a good way that even people not involved with medicine can understand how they work and that they can even come and get them done. Now, I'm going to give you a little bit of a plug here. Dr. Joe Straight, he works for First State Orthopaedics. He is doing mainly regenerative medicine, is my understanding.
So I do probably about 90% non-operative orthopedics in the office.
Which you would call regenerative medicine or pain relief through steroids, etc.
That is correct. And the PRP is an added treatment option for patients who are looking for something more, better, or we're not going to have surgery.
What's in the future? Is there, so you say, oh, it's growing, it's starting, it's rolling. What's the future look like? Tell me. Four joints, obviously.
What I see is that you're still going to have your steroids as your initial treatment options.
Okay.
But I think that eventually these other things like PRP, stem cells, and I didn't talk to you about fat stem cells because I don't do those, but that's another option to do.
Correct.
I think that they're going to probably have to come down in price and they're going to probably get approved.
Over
the next 10 years, I think we're going to need another option to help people with pain because the biggest reason patients come into my office is they hurt. It's not the pathology. It's not the tendon. They don't know about the tendon. They may have tennis elbow in the other elbow, but it doesn't hurt. They come in for pain, and they want something for pain. And I think that this works better for pain than everything else that we do.
I agree with you. Okay, so Joe, you do work for First State Orthopaedics, as we mentioned. So tell us how they get in touch with you, how they make an appointment, are you accepting new patients, etc.?
I'm accepting new patients pretty much on a daily basis.
Okay.
I'm in the office 5 days a week, pretty much 45, 50 hours a week. Patients can just reach out online, stateorthopaedics.com. They can call our number. It's 302-731-2888. That's all they have to do is ask for a consultation with Dr. Straight. They can see me for any orthopedic issue. Doesn't have to be for PRP or stem cells. If they're looking for that, I believe right now that I'm probably one of the only doctors in an orthopedic group performing these procedures. And I can give them at least the straight facts on what they should expect and what they're looking for out of these procedures.
I hope you get more business, and I hope you keep busy. 40 to 50-hour week. Maybe it'll be 60 hours. So, again, thank you, Joe, for joining us on this interesting conversation on regenerative medicine, which looks like it's the future of many musculoskeletal problems that we are having. Plus, it's going to be, stem cells are going to be used in other ways in the future beyond just musculoskeletal. I think many of you know that already from what you might have read. So this is Dr. Nick Biasotto signing off, and I hope you enjoyed the conversation between Dr. Joe Straight and myself. See you next time.
This has been Delaware Healthcare Reality, a podcast presentation of the Medical Society of Delaware. For more information about MSD, visit our website, medicalsocietyofdelaware.org. For questions or suggestions regarding our podcast, email us at healthcare.reality@medsocdel.org. Thanks to audionautics.com for our music. The executive producer of Delaware Healthcare Reality is Mark Thompson. Delaware Healthcare Reality is produced by Tom Mitten. For the Medical Society of Delaware, I'm Lori Ann Rhodes. Watch for our next podcast episode. Until then, be well. The Medical Society of Delaware, MSD, is providing this podcast for informational purposes only. It provides neither medical, legal, nor any other professional advice. The views, thoughts, and opinions expressed by the hosts or any guests are their own and do not reflect the views or policies of MSD. Unless specifically stated, reference to any specific product, service, or entity does not constitute an endorsement or recommendation by MSD. Reliance on the information provided in this podcast is exclusively at the risk of the listener. MSD expressly disclaims any and all liability or responsibility for any direct, indirect, incidental, or other damages arising out of any individual's use of, reference to, or reliance on this podcast or the information presented in this podcast.